Hello, everyone. Welcome. My name is Elaine, and I'm the training coordinator for NAD, and we welcome each of you here today to our training. So we'll give you a few minutes here to join us, to say hello, perhaps in the chat. Let us know that you're here, and we'll get started momentarily. I'll introduce our presenter today, who is Dr. Price, and I know that many of you have probably joined other trainings with Dr. Price. So welcome. Good morning. Yes, I think it is morning for everyone who's joining today. So as you're coming in, I will introduce Dr. Uzama Price. So welcome, everybody. Get yourself comfortable. Perhaps have some water or tea or something nearby and be prepared for a wonderful training. So Dr. Uzama Price is a licensed behavior analyst and accomplished scholar practitioner with over 19 years of experience in behavioral health, specializing in supporting individuals with intellectual disabilities and co-occurring mental illness in North Carolina. She's originally from Jamaica, and she holds a doctorate in education, postdoctoral training in applied behavior analysis, and a master's degree in clinical mental health counseling from Liberty University. Dr. Price has contributed to research at UNC Greensboro, designed workforce development programs across multiple countries, and led training initiatives in sexual health, cultural awareness, criminal justice, autism, and mental health. Her work has earned her prestigious awards, including the NAD Member of the Year Award in 2021 and the NC START Partner Award in 2022. In 2023, she participated in the Capacity Building Institute for the National Association of State Directors Developmental Disabilities Services, and she currently serves as the president of the Jamaican Association of Greensboro, while actively engaging with professional organizations such as the NCABA, the North Carolina Counseling Association, and the National Association for the Dually Diagnosed, NAD. So today, Dr. Price will be presenting for us on ableism and IDD. And this is the first of four training sessions that we have coming up over the next month. And they are all with Dr. Price. So welcome, Dr. Price. I hand it over to you. Welcome, everybody. Welcome, Dr. Price.
Thank you, and happy Thursday, everyone. I am super thrilled and honored to have the privilege of your time today. And as Elaine mentioned, this is a two-part series. So I look forward to picking up where we will leave off today. For the next 90 minutes, we're going to be talking about ableism, and we want to start out by doing our pre-training assessment. I'll give about 4 to 5 minutes. Once you get done with that, if you'll put a note in the chat that says done, then Elaine can indicate to me it's time to go forward. So just take a couple of minutes to get the pre-training assessment out of the way. How are we doing? Do we need more time? Seeing lots of dones in the chat. Okay. So for those of you who may need a few more moments, feel free to take the time to complete the pre-training survey. But I wanted to, before we get into the objectives, I wanted to share a disclaimer. And, we recognize the diverse perspectives on disability, bias, ableism, stigma, and all the related issues in the field of disability. Some communities may prefer person first language, while others may prefer identity first language. As we discuss these sensitive topics of bias and ableism, we encourage you to prioritize self care if you experience any form of discomfort. We hope that this information is received thoughtfully and in a trauma-informed manner as we engage in this meaningful conversation. With the work that we do, we always talk about trauma-informed environments for the individuals that we support. But as a consultant and trainer and advocate, I also think about the people who are delivering the services, the direct support professional, the administrators, the care managers, even caregivers. So we want to create environments that are safe, not only for the individuals with disabilities, but also for their natural supports and their professional support. Hence, we put this disclaimer together. All right, we have a couple of learning objectives for today, and we want to be able to define ableism and then to also describe its impact on individuals with intellectual and developmental disabilities. And we want to look at ableism through the lens of healthcare, education, and our community settings. Because the people that we support, they are members in our communities, and they are accessing many of the same community supports and services that we are using. And we want to make sure that we understand the entire environment in which people must live, grow, and thrive. So our next objective, we want to identify both overt and subtle forms of ableism, such as microaggressions, discriminatory language, and structural barriers. And we want to explain their influence on mental health, inclusion, and the quality of life for individuals with IDD. We're also going to apply concepts from the social model of disability, intersectionality, and a symbolic ableism scale to recognize systemic bias and promote equity-focused practices in the service delivery. Lastly, we want to be able to demonstrate actionable strategies to address ableist behavior, promote inclusive communication, and advocate for culturally responsive, trauma-informed, and person-centered approaches. So we're going to be covering a lot in the next 90 minutes. So again, my disclaimer, self-care. I want to make sure that everyone understands that we want to promote a trauma-informed environment, and we want you to take care of yourself in case you were to experience any kind of discomfort with this subject. So we're going to start off talking about what is ableism. Well, ableism is this pervasive societal issue that embodies stereotyping, prejudice, discrimination, and basically social oppression directed at individuals with disability. This harmful mindset, not only does it undermine the dignity of people with disabilities, but it also perpetuates systemic barriers that limit their access to the essential opportunities and resources. Now, let's look at what ableist microaggressions, what that may look like. And I want you to think through as we're going through these slides, because we'll leave enough time at the end and throughout the presentation. If you're brave enough, I want us to have open dialogue. If you want to put your thoughts and your reflections in the chat, or if we get to a stopping point and you're brave enough, you want to come off of mute and we can discuss these. So ableist microaggressions. This involves making unfounded assumptions about an individual with a disability. And typically you'll see this where the person's worth may be diminished and your potential is compared to other people, those without disabilities. The impact of ableist microaggression, it's really profound. And it not only affects the person's mental health, but it also affects their self-identity. And these subtle yet damaging remarks can have significant limits. It limits this person's ability to reach their full potential and live their best possible life. And this is very challenging for people with disabilities. It is also challenging for their loved ones because it makes it where we're not living and working and engaging in environments that are truly inclusive of all people. So when we talk about microaggressions, here are some examples. You're making like rude comments about someone's identity or their heritage. It could be belittling someone because they depend on some form of assistive technology, could be an augmentative communication device. Someone may be prying for information about the person's medical treatment or their disability. And oftentimes, microaggression was not intended to insult or offend the person with intellectual disability. Most people are doing these things and they're not doing it to be harmful. I want to make sure that we are clear about that, that the intent is not to cause harm. Now let's talk about eugenics and oppression. Eugenics emerged as this powerful ideology across the globe in the 19th and the early 20th centuries, and it resulted in systemic oppression of countless individuals with disability. Now, in today's world, the rapid advancement in genetic testing and gene editing does pose some ethical challenges, which threatens to usher in new eugenics. And we should be advocating for society that values and includes all individuals, regardless of their capabilities. So regardless of our ability or our disabilities, we should be looking at each and every person as being valued, as having a place in our communities, of having a place in our school systems, in our church of worship, in anything that we find value in. People with disabilities should be a part of our communities. And when we oppress people and when we make people feel othered or less than, we are not helping that. The environment isn't set up for all people to feel like they are welcomed in spaces. When we think about mental illness and disabilities, people face mental illness rates that are comparable to other people without disabilities. But we know that the barriers from accessing mental health care or physical health care is significantly higher for people with IDD. And we know that folks can experience all sorts of trauma from trying to engage in a system or in a structural system that is not conducive to all people. I'll sometimes say when I'm consulting on cases that I know many people with intellectual disabilities, many people with autism, that they didn't come into this world. They were not born with mental illness. They were not born with anxiety and depression, but their interactions with the system to gain the services that they need created this anxiety, created this depression. So we know that people with disabilities may have more difficulty accessing systems, and they do have higher unmet needs for all types of services, including mental health treatment. And we know that people within this population, they are only about 25% of the folks within the United States. So people with disabilities face mental health rates that are comparable to people without disabilities. If we think about the Journal of Social Issues, this goes back to 1988. They did this study, and they were really looking at how we conceptualize disability as a minority group and a social issue. And what they got out of that is that the subjective experiences of people with disabilities, sometimes that is minimized. People's voices are not being heard in a meaningful manner. We are failing to have true impact on the quality of life for people with disabilities. And even today in 2025, many policies are failing people with disabilities. It's almost as if we bring people to the table, but are they really represented? So James Charlton wrote this book, Nothing About Us Without Us. And we hear this verbiage quite a bit. But disability oppression and empowerment is really important for us to understand. And over a 10-year period, they interviewed disability rights activists across Europe, the United States, and third world countries. And what they were trying to do was move from oppression to empowerment so that every single person who is at the table, their voice is actually being heard. And that's what we want. We don't just want to be invited into spaces. People with disabilities, they have a voice. They know exactly what it is that they want and need and desire. But just being invited to the table is not good enough. It was never good enough. What we want is to have skin in the game, if we may say that. We want their voices to be heard. People want to know that they belong. How do we combat ableism? Well, we really need to challenge and dismantle any kind of ingrained stereotypes because we know that it is harmful and it is damaging, not just for the person with the disability, but for their natural support systems. And it's imperative that we work towards a society that values inclusivity, one that champions equity for all individuals, regardless of their abilities. And when we really embrace people, then we're able to treat people with the dignity and the respect that they deserve. Now, Keith, in 1996, talked about doing disability all day long. And I'm going to read his quote. Doing disability all day long can be an exhausting process. I don't mean having an impairment. In my own case, not being able to walk. Like most disabled people, I can deal with this. I mean, having to spend a significant part of each day dealing with a physical world which is historically designed to exclude me, even more tiring, dealing with other people's preconceptions and misconceptions about me. And I think this is a powerful statement coming from somebody who is using a wheelchair for mobility. What this man is saying that the preconceptions and misconceptions of people, like, that is exhausting. So I'd like for you to put in the chat, or if you feel brave enough, come off of mute and share your reflections. What are the first thoughts or emotions that come to mind after reviewing the information on this slide, with Keith talking about how exhausting that can be to deal with people's preconceptions and misconceptions about him and his disability? What are your thoughts? When I've discussed this in other settings, some of the comments I'll get from attendees that it makes them uncomfortable and they feel badly that this is the part of the disability journey that is very exhausting. And they find it surprising that it's dealing with other people's impression of who they are as the biggest part of the disability, and not that the fact that the person may need to use an augmentative communication device or use a wheelchair for mobility. All right, we've got one answer in the chat. Keith makes it sound like the hardship of disability comes not from his physical impairment, but from the way the world treats and views him. Correct. Thank you so very much for this comment. That is exactly what I hear in other spaces when people are viewing this slide. Yeah, and that to me is very profound, because he's made, from what little we have here, he's made peace with his disability. He's able to live his life, but it's interacting with the rest of society what he finds to be exhausting. Any other comments in the chat? Found that it creates space for imagining a world not where disability doesn't exist, but where its supports exist. Perfectly said. And Tamara said, it really requires us all to change our assumptions and our behaviors. Absolutely. Absolutely. And something that we should think about. We're not bad people. We're in this field and we are here to do good. We want to help others. We're helpers. But even we have to check ourselves and check our compass and make sure that we are getting supervision, that we're talking to our colleagues, and that we're really checking our own compass to make sure that we are bringing solutions, and that where we find that we may have some blind spots, that we're actually addressing those. So let's look at the ableism fact sheet. Ableism manifests when society expresses pity or casts blame on an individual for their disability. This harmful mindset overlooks systemic barriers that individuals face, and it's particularly troubling for people living in impoverished communities where they may have limited employment options, lack of educational resources, and those things further exacerbate their challenges. And we know people with disability within our communities, they do experience more trauma than other people, whether it'll be folks with just mental illness or physical disabilities. And this is something that we really have to think about when we are looking at quality of life and how people view themselves. How is ableism and the structures and the environment in which people live, the social determinants of health, how are those things being impacted by ableism? And Jacobs in 2021 looked at ableism and natural disasters. And you think about what happened in COVID. And COVID wasn't so long ago. And I'm sure that many of us are still healing from our own traumatic responses from what we went through with COVID. And we know these deeply ingrained assumptions that people with disabilities are somehow less valuable often lead to exclusion from critical resources and support. And that this bias not only undermines their rights, but it also jeopardizes their safety and well-being in a time of crisis. Think about people who are living in congregate setting and not having personal protective equipment. Think about people who, when they're working with their staff, were ending up having major behaviors because now staff, they're using a mask to cover their face. But the individual that they're supporting, they need to be able to look at their face and look at their lips in order to communicate. And that is now out the way because the personal protective equipment, this person is now wearing a mask, and this is impacting their ability to communicate. So even in the space of a natural disaster, ableism is a concern. And in order for us to really support people, we need to think about folks with disabilities the same way we do with folks with abilities. Whatever services people need when they have an IQ that's over 70, or when they don't have any physical limitations, it should be the same across the board. And that's where we come in as helpers, as activists. We need to make sure that we are understanding all of the needs, not just some of them, but that we understand globally what is happening within our healthcare system. Medical providers, in this one study, often approach the delivery of care from preconceived notions. And what we're talking about is that they equate disability with some diminished quality of life. And despite substantial research that disproves all of this, it still prevails in our healthcare settings. And it not only undermines the validity of the patient and their experience, but it fails to recognize the diverse perspectives on disabilities and how that may affect people. Now, this study from 2023, I thought this was really interesting, that these are medical residents in school. And the study was looking at how comfortable they were and their overall experience of being affected by ableist culture within their programs. And 48% of residents did request some sort of accommodation. 50% of them chose not to request accommodations. And the primary reason that they gave for not requesting accommodation were fear of stigma, concerns about bias, the absence of a standard policy for initiating some sort of request for an accommodation, and the prevailing culture of ableism within the medical field. Now, to me, this is concerning because this is within our healthcare setting, and these are medical residents learning and growing and trying to professionally develop themselves, but afraid to request an accommodation because of a culture of ableism and this fear of stigma and bias. Now, I would love to hear your thoughts in the chat. What do you think about this research that O'Reilly and Salas did in 2023? Do you find this to be troubling that this could be the experience of these medical residents in their program? Laura says, very troubling. Stigma is powerful. We all want and need belonging. Yes, we do. Maslow's theory. And Judith says, I do find this deeply concerning. Sad, not surprising. Yeah. Yep. So we see how prevalent this is. And imagine these are medical residents in their program. Imagine the people we are supporting with intellectual and developmental disabilities. Imagine their experiences. And think about those that may have expressive language deficits that may not be able to express how they feel, but they know they don't feel welcomed in certain spaces. Now, when we think about ableism and institutions, think about places that you have visited recently in the community and maybe environments in which you have worked in. And let's think about institutions and public spaces that may have limited access for people with disabilities. Maybe they don't have ramps, or they have ramps, but there's no elevator, or they have limited parking spaces in the front. I have been to many places, I mean, parking lots for huge stores, and there are only 3 spaces in the front for people that may need some accommodation with the parking spaces. Let's think about going into a medical provider's office and they have limited access to Braille, or they don't have anyone or access to American Sign Language. We think about within programs or policies and service delivery models that exclude the voice of people with disabilities. And we even think about in the school systems where there is lack of person-centered accommodations. These are all very problematic, and these are just examples of what ableism looks like within institutional settings. Consider someone who's living at home with family, and in their home, they're able to use a Hoyer lift to get from the bed into the bathtub. Consider this woman is in her 40s and she is supposed to be going to the doctor's office for an OBGYN appointment. And there's an exam table. She's able to get through the automatic doors. Her wheelchair that she's using for mobility is able to get onto the scale in the doctor's office. No issues there. However, we don't have anything. There's no Hoyer lift, no equipment to get her from her wheelchair onto the exam bed. Think about how many people may not be able to get their healthcare needs met because of the medical facility may not have all of the supports and services and resources in place to facilitate a pleasant experience, one that is wrapped with dignity, respect, and support. Imagine what parents and caregivers may feel like when they're engaging in community settings, medical facilities, and the resources that they need are not in place. Imagine what that may feel like. Any comments in the chat? Let's see what we got. Curious if ableism is lower in other countries. Laura, that is a great, great question. I was doing some reading about ableism in other parts of the world. And what I learned is the word ableism may not be, there may not be that full translation in other countries. So like in Africa, there's no direct translation for ableism, but the attitudes where people with disabilities may be treated less than, or they're not considered, that yes, it is there. And we know that in European countries, it is the same thing, but they are somewhat progressive, and there is lots of activism and lots of support of us, needing to be inclusive and what that looks like. So it seems that globally we have lots of challenges, but they may not necessarily use the same words we use here as ableism because there may not be a direct translation. Thank you for that. That was a good question. Now let's look at ableism and autism. The effects of ableist culture on autistic people include victimization, isolation, underemployment, and mental health challenges. I'll have to say that I try not to be on social media a whole lot, but yesterday I had, or was it the day before? It may have been the day before. I was asked to come to a case consultation with a transitional age youth. This is a young man that just turned 20. And he's very much in the news, knows everything that is going on. And, you know, I just haven't paid a lot of attention here lately. And he wanted me to know that he was so bothered by what he'd heard in the news that autism was considered a disease and that people didn't like other people with autism because they were not going to be able to pay taxes and things of the sort. And he was really hurt by that. And I so wasn't prepared for that conversation. I had no idea where the conversation was going to go, but I ended up apologizing and letting him know that that negative view is not held by the rest of the world. And, what he saw, that was just the opinion of one person. And that people with autism, there are many people who are thriving. There are many people who are working. There are many people who are volunteering. And yeah, maybe they do have some mental health challenges, but that's why we're here. We're here to advocate. We're here to support. We're here to train folks and, teach. So I put that out there because this just happened. And I was just like, oh my goodness, I really was not prepared for that. So I am curious, have any of you had any conversations with people diagnosed with autism or autistic folks who may watch maybe way too much news and they are bothered by how people may view their autism? Curious about that. Judith says yes. Thank you so much for sharing that, Laura. Tamara, you said Kennedy's most recent statement was offensive and insensitive. Absolutely. Because after I talked to this young man, I had to go and read myself because I could not believe that something like that was said. All right, when we think about intersectionality and ableism, we all show up in spaces with many different forms of who we are. And multiple forms of discrimination and disadvantage, they do interact and they profoundly impact people with disabilities. As allies, I think that we need to recognize intersectionality through the lens of ableism and understand how disability interact with other identities. So I'm talking about race, gender, sexual orientation, and even age. And then we really need to acknowledge that these intersections reveal unique challenges. And it's and empowering us to advocate for people because we really need a more inclusive and equitable society for everybody. Now, I mentioned before about the prevalence of poor health within the IDD population. We know sensory impairment is an issue. I know I work with many people with fetal alcohol spectrum disorder and autism, and they do have a lot of sensory challenges. We know that there are a lot of people who are so sensitive, they're not able to tolerate going to the dentist. We know nutritional issues are concerned. We know folks have epilepsy, mental illness, lots of trauma in this population, asthma, diabetes, obesity. All of these are concerned for our folks. So when we think about health equity, each person, regardless of their disability or ability, they should have access to resources to ensure that they are as healthy as possible. And ableism is considered a social determinant of health because it impacts the health outcomes of people with disabilities. And we think about ableism in research. When the general population encounters autism, it is often through this restrictive lens of the medical model, right? Which looks at this is a problem, we're the experts, we're here to fix it. It's all about this person and their deficit. This approach fosters this misleading notion that autism requires curing, that we don't see the brilliance and the beauty of people with autism. And that's problematic because as a result, autistic individuals frequently are seen as abnormal. This perpetuates this stigma around their experiences and their identities. And we really need to reframe this. I know I've worked with people from the Middle East, and in their culture, they look at autism as a superpower, that they are blessed to have an autistic person within their family. And whenever I'm in spaces and I hear things like that, it makes me feel so good because that's really how I personally feel. Like we're all beautiful individuals and we all have value. Now, something that I didn't used to think about, maybe 10, 15 years ago is the inspiration porn. And this didn't occur to me until I worked with a family. And they were trying to explain to me that they find this to be very harmful, where they feel like they're objectifying the person who is disabled, right? And they're making them, giving them accommodations, or even like giving an award for something that if it were another person, they would not do that with, like making them the biggest fan, the team mascot, or the team manager. And they're frequently celebrating them in these capacities. And even though they mean well, there's some people that would take offense to that. This may provide some sense of fulfillment for the audience of people who are non-disabled, but ultimately it serves to reinforce this feel-good narrative that doesn't really address the bigger problem, which is inclusion and representation. And that's not something that I had thought about till I actually worked with people and they shared that that was definitely a concern. Now, when we think about ableist language, think back in your mind to treatment plans you may have read, diagnostic assessments that you may have read, where people are talking about autism as an epidemic. Here, what this young man was telling me, that autism was said to be a disease, where we look at the burden of suffering when we use word at risk of. Those are all negative. And what we are proposing is that we use other words. We could say autism as increasingly recognized as a diagnosis, co-occurring, impact, the effect of, seeking support services, educational strategies when applicable. All of those sound a whole lot better than the negative language, and that's what we want to talk about. Saying this person's got challenging behavior, they're disruptive, they've got problematic behavior. How about self-injurious or aggressive behavior? And then follow that up in what environments will we see these behaviors? Now, when we think about sensory differences in autism or for folks with fetal alcohol spectrum disorder, many people are struggling in certain environments because the environment is not set up to support all people. And folks with autism are just, in many instances, they're very vulnerable because the environment around them may not understand that they're hyporeactive to sensory input, and they may not be aware of certain stimuli. They may be eating and they've got crumbs all over their face. They don't feel that. And staff may say, "Don't you feel like you've got crumbs on your face? Why does your face look so messy?" People may not know that they are hyperreactive to sensory input. They may need more sensitive, they may be more sensitive, they may need more stimuli. That's going to be the person that's going to give you that really, really, really tight hug. They may be uncomfortable in spaces with clanging doors, loud noises, bright lights, too many people. They may even cut and they're bleeding and they're not even aware of it. And if staff is coming up to them and, chastising them, that can create issues. So we know touch, certain smells could be a problem. And we should also think about not all disabilities are visible. People could be sensitive to strong perfumes and things of the sort. So it's not everything we're going to be able to know just off, just looking at someone. We think about stigma management strategies, things that people are having to do to tolerate being in certain spaces. That's passing, that's attempting to hide the stigmatized identity by pretending to be a part of the unstigmatized majority. Social camouflaging. This could really contribute to anxiety and depression because people are going to try to suppress, say, their stimming behavior because they want to be included. Autistic masking as a social survival strategy, it should not have to happen. But people are using that to conform to expected norms and to cope with situations or environments to avoid expressing anxiety. I had a young man that overdosed in his autism on his Vyvanse, his ADHD medicine, because everybody was going to the bowling alley for the holiday. And he wanted to be there on this Friday night, and he knew that it was going to be too overwhelming for him. And instead of talking with his mom or with the care manager, he decided to just take a lot of his medications. And I don't really believe that people should have to overdose on medications to be in spaces where we are. I just believe that all spaces should be made available for everybody. So when we look at disability statistics in the state of Oregon, we know that a lot of people are living in poverty with disabilities. We know that not a lot of people are able to work. And if you look at who's employed between the ages of 18 to 64 years old, we're only talking about 17.7% to about 51%. What about the other people? What are they doing? Are people really living an independent life? And what we're seeing here is that independent living is difficult. People with cognitive difficulties are struggling. So it's not only in the areas where you work. I can tell you in North Carolina, we've got the same issues going on here. So the other thing for us to think about is, how does culture affect the work that we do? How does culture play into ableism? And we know that culture could be internal, it could be external, and it's really frameworks of how we are socially interacting. It's intergenerational and it's transferred over time. And frameworks of culture offer individuals a lens through which to understand and make sense of the world. And because we are NAD and we believe in the biopsychosocial approach, we value and celebrate the differences in people. That multimodal biopsychosocial approach looks at culture, gender, it looks at age, it looks at how we learn, it looks at our trauma, it looks at our physical health needs, it looks at a whole person. And we at NAD believe that in order for us to be good stewards and take care of people, we need to be doing the same things. So when we think about the National Organization for Human Services, they're saying that there's some fundamental values that we should be bringing to the table as professionals: respecting the dignity and welfare of all people, promoting self-determination, honoring cultural diversity, advocating for social justice, and acting with integrity, honesty, genuineness, and objectivity. These are the things that we should be doing. And the same way we want equal access for our loved ones is the same thing for people with disabilities: equal pay, freedom of thought, freedom of choice, and protection from discrimination. We know the Western model has looked at disability as a problem, and we are the experts, and we're coming in here to fix the problem. To look at the person with the disability as being the problem. And we as experts are here to fix that person. That's a problem with that model. And the social model, on the other hand, they're looking at how does the community, how does the environment contribute to this person's lived experience. And in the social model, they're looking at badly designed spaces, inaccessible transportation, lack of sign language interpreters, chronic health condition, isolated families, and discrimination as being what is disabling to the individual. And if we think about what Keith said, he can deal with his disability. It's the people around him and their preconceived notions and misconceptions about him that is troubling. Now, that's the medical model, social model. We look at things through that biopsychosocial lens. And this is truly medical humanism, because the biopsychosocial model is a way of understanding the patient's experiences as an essential contributor. And for us, we need it for accurate diagnosis of a problem, for positive health outcomes, and for effective human care. And when we are able to recognize overt ableism and subtle ableism, and we can call that out, we are truly helping people. So let's look at a few of these examples. When children are punished for behaviors related to their disabilities, that's very overt. But subtle ableism is when we're using terms like blind spot, tone dead, tone deaf, you're crazy. That's more subtle. Either way, they're both troubling. Not making accommodations for school-age children related, to ensure that they can remain in school. That's very overt. But arranging activities without considering all of the people who are going to engage, like this young man who wanted to go to the bowling alley, but no one thought that that may not be the best thing on a Friday night for people with sensory difficulties. That's more subtle. What we're inadvertently telling people with disabilities is like, I don't see you, I don't consider you, you just need to fit into this environment. And that is problematic. So we need to be able to recognize overt ableism and subtle ableism and be able to feel comfortable calling these things out, because there's not going to be a way to address this without really bringing it to life. Because again, many people are engaging in behaviors and they're not doing it to be harmful. When we think about belonging and disability, we all want to belong. Maslow's theory of hierarchy. Everybody wants to belong. But when belonging is challenged, it can impact the person psychologically. Each person wants to be valued in their community. They want to be a part of, they want friends. They want to be able to say, I'm a part of this group. This is my organization. I come here and I do yoga. I'm a part of this nonprofit. Here are the things that I do when I volunteer. Belonging, when Maslow came up with his theory, he did not say that belonging was only about people whose IQ is over 70. No, he did not say that. The pyramid of needs was for all people. And when a person feels satisfied with their station in life, they truly feel like they belong. Now, moral injury, historically, we thought about moral injury with people returning from wars. But here, since COVID, I've been looking at many studies looking at the moral injury of healthcare workers. And we know individuals who are exposed to traumatic events that violate their moral values may experience distress and some functional impairment. Imagine you are working in the emergency department and this person comes in and they've got lots of violent behaviors, but you don't have any beds. And you have to discharge this person home knowing that they are unsafe, their family members are unsafe. Many people feel morally injured. And that's something, if you are an administrator or you're designing a program, we should be thinking about the moral injury of our workforce and how we can help people to coach them up. How do we get them into counseling or, in groups that can help them to address those feelings, because it is real, it's not imagined, and it can really lead to burnout. So here are some ways to combat ableism. Attitudinal. When we ignore, judge, or have misconceptions about a person with a disability, we call that, it's an attitude. And we need to be able to call that out. When we're looking at our policies and our procedures and they unfairly discriminate against people, we need to be able to call that out. When we see designs of buildings and the layout of rooms and we're not thinking about all people, if it means that we've got to call our county commission, we need to do that. When the accommodations for people with disabilities are not being considered, whether it's in a training or the person's going to the movies or something like that, and those accommodations are not there, we need to gently let people know. When we're using technology and folks with disabilities are not able to access that, and there's no assistive device if they're going to a doctor's office, we need to be able to call that out. Now, everything that we do should be respective. We should be respectful, but we should still be effective in our communication. Now, here are some things from the field that they're telling us that we should be aware of. Don't pet someone's service animal without getting permission. Don't push someone's wheelchair if they didn't ask permission. And resist the urge to, get impatient if you're standing in line at Walmart behind somebody with a disability. And don't give awards or accomplishments by a person with a disability where the award is for something that wasn't really challenging. And again, I mentioned that not all disabilities are obvious. So strong fragrances can cause a reaction for people with sensory sensitivities. And I sound like a broken record in many instances, but not all disabilities are visual. Now let's think about an ally and accomplice. Allied behavior is about actively supporting or supporting our community members by raising awareness of causes that expose and challenge inequitable systems. Accomplice, those behavior demand overt, measurable, intentional actions that consistently confront and dismantle patterns and systems that oppress specific members of our communities. So, I have a friend, he's a wonderful guy. We've worked together maybe like 10 years ago. We're all a part of a same group. He's got some restricted, interests, and he loves to talk about his clocks. We all know one of our friend from our walking group. She was getting married, and we meet quite occasionally. I got an invite to the wedding. And I was asking, we'll just call him John. Hey, John, did you get an invite to the wedding? He's like, no, did you? Of course, I felt badly. So I messaged a couple people and I'm like, hey, what's going on? I thought, we've been hearing about the proposal. We all going to this wedding together. What's going on? And my bud did not get invited. And when I probed a little bit more, it was about, well, we just think that, he's going to embarrass some folks and he's going to keep talking about his clocks and whatever. And I'm like, that's all you could think about? You couldn't think about how gorgeous he is with his blonde hair and his green eyes and that he's a really good dancer? I was looking forward to being at this reception with him. And because he did not get invited, and even though I got one, I could have showed up and let everybody know that I was not pleased about that. But I wanted to be an accomplice. And what I did not go because I didn't feel comfortable with that. If he's good enough to be hanging out with us and be a part of our walking group, and we've been doing this for how long now, I didn't understand why your relatives and friends couldn't see the beauty in him. So that's the difference between an ally and accomplice. How put in the chat, I'm curious. Have you heard the term accomplice used in this context? Okay, lots of no's. What are your thoughts? Thank you, Judith. What a wonderful idea. Yes. So here's an example of spotting ableist signs. So this is in a day program. It's in a rural county here in North Carolina. The DSPs and their supervisor, they do a 30-minute meeting at the start of the day. And this is when they're talking about authorizations, daily schedule, health and safety issues, incident reports. So they're just catching up on all things. Sal is complaining about his sensory sensitivity. Judy is becoming upset, and Judy makes a comment. Learn how to cope. It sounds like you're just OCD and bipolar. How come nobody else is bothered by my perfume? Now, I want us to think about this little scenario and let's have a group discussion. Feel free to come off mute or put it in the chat. What do you think about this comment? Just learn how to cope. It sounds like you're just OCD and bipolar. How come nobody else is bothered by my perfume? If you were in an environment and something like that were to occur, how would you feel about that? Disrespectful. Absolutely, Stephanie. Absolutely. disrespectful. I've heard people say just really offensive behavior, not not acting as if we're all on the same team because you're signaling, you're signal somebody out and you're singling them out, and it's hurtful, and that should not happen. So for this group, um, what we talked about is, how would we do that? How would you do this if you were in an environment where that happened? And this is a part of the training that we've done in the past, where we don't want to create chaos. Remember, this is a public space, and the individuals being served are not too far away. They're in another room, but they're having this discussion in the boardroom. And one way that we can disrupt ableist behavior is to do just that, disrupt it. Hey, Judy, let's get back on task. We can also confront. Judy, I'm giving you the benefit of the doubt that you didn't realize that your comment is hurtful and offensive. We can be supportive. Billy, what Judy said was not appropriate. Are you okay? I'm sorry this happened. Let me know if you'd like me to assist you in reporting this. Somebody decides that they want to report. Hey, this is John. Today during huddle, one of the DSPs made a statement about one staff's disability. Learn how to cope. It sounds like you're just OCD and bipolar. How come nobody else is bothered by my perfume? This wasn't very respectful, and it reminded me of the training we did back in 2020. So what this person's talking about, back in 2020, they had gotten a grant, and the day program had done like a comprehensive training around bias, ableism, stigma. They'd gone through all of that. But what has happened since COVID, and in the 4 years, they've had a high turnover. And so they've lost a lot of staff, they've gotten a lot of new staff. So it's quite possibly the person who engaged in this behavior may not have been there in 2020 when they did this training. So looking at this slide, can you tell me who is the ally, and can you spot the accomplice? And you can put that in chat, or you can come off of mute. We want to see who's the ally and who is the accomplice. Very good. I'd say the accomplice confronts. Exactly, exactly. I agree with that. Now, when we think about the medical model, we look at people as being things that we need to fix. And that's an F word that I don't like. The F word is out of the medical model. I want us to use other F words: fitness, function, friends, family, fun, future. Those are the F words that we need to use. We need to shift away from thinking we need to fix people. We need to know that people are fine just as they are. We need to help people to function better. We need environments to be respective and responsible and responsive to the needs of all people. Spaces need to allow everybody to come and be their authentic self. And those are the F words that we want to use. Not think about people like something that needs to be fixed, because we're not miracle workers. We don't fix anything, and we don't cure IDD. We don't cure autism. If you have an hearing impairment and you put in hearing aids, it helps you to function. You can hear. It's the same thing with glasses. We're not trying to fix people. We want people to be able to function in their communities. Now, we have a short video. Elaine, if you don't mind, if you can put that link in the chat. We want to look at perspective taking. This is a quick video that is about 2 minutes long. I want you to click on this YouTube video, take a look at it, and we're going to hear her perspective on her frustration of dealing with folks who don't understand or remember about her disability. And when you get done, come back and put a note in the chat that says done. And remember, when you are done viewing the video, if you put a note in the chat that says hey, seeing a few dones come in. All right. Well, thank you for viewing that. Love to get your perspective, hearing what are your thoughts about this video. What are your thoughts? Insightful and troubling that you can't discuss a problem without first naming it. Yeah. Yes. Humbled. Yeah. Yeah. Thank you for sharing that. Now, I believe in Nussbaum's capabilities theory. And this theory believes that we are all capable, regardless of our disability or our ability, that we all should be able to live to old age. And that being able to live, we're living a full life. And we know that we want to improve the quality of life for people with disabilities. And the capabilities approach things that we all should have that. And that people should have a choice in their reproductive health, sexual satisfaction, and safe space. And I know a lot of these things are controversial, and we could be here all day discussing that. But the capabilities theory, this is what they're saying. and that people should have freedom of religious expression, freedom to speak, and to be creative, and that they should have the ability to have relationships with others if that is their choice. And they should be able to plan their life, and they should be free to connect with others and be treated with dignity and with respect. And they should have concerns for their environment, for human nature, for animals, for plants. And they should be able to laugh, play, and enjoy recreational activities. And they should be able to exercise their political choice. They should be able to seek employment. They should be free to own goods or procure services. And what Nussbaum is saying, that we are all the same, and we all deserve to be treated with dignity and respect. And we should all be in a position to improve our quality of life. Now, the symbolic ableism scale, and I don't know if many of you have heard of this, but this is something you can look at later on. You'll have access to the slides. But it's a crucial tool for uncovering subtle prejudices that persist against people with disabilities in our society. And it's a framework, and it revolves around 4 key themes: emphasis on individualism, recognition of ongoing discrimination, cultivation of empathy for disabled individuals, and identification of excessive societal demands placed on people. And I think we can all benefit from learning more about ableism and how to confront it. So I would say, in the environments in which you have worked and you've been thinking about it, as ableist culture permeates the air, or even in spaces that you are in currently now, how can you become an ally or become an accomplice? Anderson in 2010 wrote his book about gracism, and offering gracism. And I say, I am a gracist because I want to do what Anderson says: treat all people equally, celebrate with people, honor those who are invisible, educate myself when I don't know what I think I should know, and come into spaces with cultural humility, where the individuals with a disability are the experts. And I am here to learn and protect people from mistreatment and stand in unity with others and realize my privilege and consider the needs of all people. That is gracism. And that is why I say I am a gracist, because I stand with people with disabilities. I celebrate people with disabilities. And I honor the voices that are not at the table. And I am an accomplice, because even when it makes other people uncomfortable, I am willing to stand up. I am willing to shed light on what is happening. I am curious, how many of you have heard of the term gracism? Not until now, not until today. Well, I am so glad that I was able to share some tidbits. Thank you, Rachel. Thank you, Judith. Thank you, Tamara. Thank you, Colin. New to me. Wonderful. Well, we've got lots of resources, and this will be in the slide deck of things for you to look at later on. If you are an educator, or if you're an administrator and you're supervising others, lots of resources that you can use. You think about ally behavior, you think about accomplice behaviors, and what we can do to make things better for folks with disabilities. So we are nearing the end of our presentation, or we're done with our presentation. We do have a few minutes. Would love for people to put comments in the chat. if you have any, but I do want to give about 5 minutes to complete the post-training assessment. Any comments or reflections that you would like to share? Thank you so much. I appreciate that. It is my pleasure to be here. I am honored to have the privilege of your time. This has been a great opportunity for me. Thank you, Judith. I appreciate that. And we have to be good stewards, right? So we thank all the great people in the state of Oregon that thought that this was a worthwhile endeavor for us to have this two-part series. So we'll talk again about, bias and what we need to be doing to challenge that as well. And Tamaria said there's so many institutional issues here and requires a lot more than individual effort. Absolutely. For example, people are often excluded from research. Yes, because they are considered part of a vulnerable population. This translates into exclusion from criteria for accessing evidence-based practice. You nailed it. You are absolutely correct. There are many institutional review boards that they think that, harm will come to people, but how will we know how people with disabilities are going to do on certain medications? How do we know their perspective on sexuality education topics that they want to know about? How do we know about their lived experiences about being in a psychiatric facility when they are dually diagnosed with post-traumatic stress and intellectual disability? If we never give them an opportunity to be a part of research, then we will never be able to hear their voice. And you are absolutely correct that they are excluded from research, and that in and of itself is problematic. Thank you for that. Thank you, Rachel. You said that you're learning how to be a graces. Thank you. And I am looking forward to our next training. Yes, that we should be using evidence-based practices. Yes. And it does exclude folks. So yeah, there's a lot that we need to be working on, a lot that we need to be working on. Thank you, Laura. I appreciate that. And I am looking forward to our next talk. You are welcome, Tamara.
Thank you so much, Dr. Price. This is Elaine. I'm just saying, wow, wow, wow. What an insightful training. I
Oh,
really, really enjoyed it.
oh,
Thank you
thank you
so
so
much.
much. Thank you. I
Yeah.
appreciate the wonderful comments. Thank you.
Yeah.
This has been a wonderful opportunity to do this. So I am grateful. I'm grateful for you all allowing me to do this.
Thank you
Dear,
so
dear to
much.
my heart, dear to my heart.
Well, we can tell the topic is dear to your heart, for sure. Yeah, for sure. So thank you, everyone. We want to give you a couple more minutes to finish up the post-training assessment. It's really important that we have your feedback there as well. It's an evaluation as well at the end of the 7 or 8 questions, however many questions there are in the post-training assessment today. So please do complete that and feel free to share or pose a quick question if you've got something that, oh, I just thought of something. You can answer, you can ask it quickly there in the chat if you'd like. And as Dr. Price said, we'll be back with you again on May 15th for really a part two, which is
Part
bias
two.
and IDD. And then Dr. Price will be with us again June 5th and June 12th for parts 1 and 2 of another great training, and that is innovative therapy and service approaches for individuals with IDD. So that's loaded.
Yes, yes, yes,
Loaded
yes.
training, lots of great information and resources there as well. So we thank you all for being here. And as Dr. Price said, we're grateful for the opportunity to deliver these trainings
Yes.
for Oregon Health Authority and to
And
be with
thank
you.
you, Jessica. This has been wonderful.
Yes, it has. Thank you, Jessica, for the collaboration. And we look forward to being with you again. So any final comments, Dr. Price, or from anyone you want to share something in the chat before we close? Thank you all. Thanks for being here. Thanks for everything you do. And we'll see you again on May 15th and then again in June.
Yes, thank you, everybody. Goodbye.
Thanks, Dr. Price. Thank you,
You're
Jessica. Thank you
welcome.
all. Bye-bye for now. Take good care.
Thanks so much.